the chat?
Sure.
It's really
Yeah. All right, we'll get started with our first small talk. I'll hand it over to Andrea.
All right, hello guys. So today is endocrine day, as we all know. So I'm talking about insulin pumps. Not going to go into like I'll talk about what an insulin pump is. Well, we'll go over the objectives in a second, but basically my goal for this lecture is to introduce you all to insulin pumps and then what you might encounter in the ED and why they matter in the ED. Probably not in our population, but in the future. Okay, so these are our objectives. So first, we're just going to talk about the history of the insulin pump very briefly, why we care about them at all, an overview on how they work, problems that you might see in the emergency room, and just takeaway points and hopefully we'll have time for questions. Okay, so the first insulin pump was basically, it was like the size of an army backpack. I have a photo on the next page, but it was invented in 1960. Not very practical, as we'll see in a second. The first open loop pump, and we'll talk about what open loop versus closed loop means in a second, was made in 1974. There was another prototype in the late 1970s called the Mill Hill Infuser, and then there was the big blue brick in 1978. So a lot of insulin pumps were developed in the 70s. They had some issues, but the very first one was 1960. So here's the very first one. Looks like a very large backpack. The one on the right is called the biostator, and that was actually like almost like a computer, but it would connect to the patient who would be like in the bed. So not very practical for carrying around. Here at the top, you'll see some different prototypes from the 70s. On the right is the big blue brick. So that was like the first wearable insulin pump. And then at the bottom is an arguably more important pump that was developed around the same time. Didn't really catch on. So these were some of the major issues. There was phlebitis, thrombosis, infection. They were very cumbersome and heavy, and there wasn't a lot of flexibility in the basal insulin rate, and a lot of needle dislodgement issues. Okay, but now we have these very nifty devices. As you can see, a lot of them use a smartphone, which is pretty cool. And these are the three big ones on the market right now. So we've come a long way with insulin pumps. So the reason that these matter is that 80% of kids with type 1 diabetes have a hemoglobin A1C greater than 7%. And that's like a current value. So some of this has to do with compliance, but a lot of it has to do with type 1 diabetes itself. It's just still a very difficult disease to manage throughout life. But even in childhood, when they're diagnosed, they still have a lot of difficulty managing. So for that reason, insulin pumps are very important among that particular population, the type 1 diabetes population, especially in kids. But as we are developing more and more technology, they are becoming more popular and usable in patients who are type 2 diabetic but insulin dependent. So these are just some kind of statistics on, whether this is really better than insulin injection. So they found a 0.3 to 0.6% reduction in hemoglobin A1C for CS2, stands for continuous subcutaneous insulin infusion. That's just another name for an insulin pump, right? So anytime you see CS2, that's like an insulin pump, and II is just insulin injection. So not a huge difference, 0.3 to 0.6, but it's something. And then the more important value, I think, is this one here, that the rate ratio of severe hypoglycemic events for insulin injection compared to CS2 or CSII is 4.19. So you're 4.19 times more likely, if you're an insulin injector, to have severe hypoglycemic events than someone with a pump. Okay, so here's kind of just how the set works, right? So you have this infusion set, and that refers to like the adhesive and the cannula. You have tubing, and then you have the device itself, which has an insulin reservoir in it, and it also has a battery, and then it has buttons that the operator can use to adjust different settings. But these are kind of the three places where things might go wrong if you see an insulin pump in the ED. So you have to think about the infusion set, the tubing, and the device itself. Okay, so we'll spend a little bit of time on this slide here. So kind of the four major things to think about when like the things that make an insulin pump work, right? So the first thing is the insulin type. It's always short-acting insulin. So people on an insulin pump never use long-acting. It's always short-acting. And then there's two different patterns for insulin delivery. So you have a basal rate, which is like constant background insulin infusion. That's going to be variable between individuals and across a 24-hour period. So even the basal rate is not a constant set number. Some people will have different basal rates for like when they're working or when they're working out versus when they're resting. And then the bolus insulin is just insulin to cover your carbohydrate intake. So that's like your mealtime insulin. And then there's different patterns with that too. So there's all these, you saw there's a couple different buttons on there. So the users themselves, which kind of gets back to like who would benefit from an insulin pump. It's someone who like is able to do these calculations because they can do certain calculations like an insulin carb ratio so that they know about how many carbs are in the meal that they're about to eat, and they can enter in an insulin to carb ratio, and then they can adjust their bolus dose like in real time. Another just term is, so the insulin carb ratio is a big thing that users actually know how to input themselves. And then there's an insulin sensitivity factor, which is an individualized ratio that allows population of a correction dose. So people can actually calculate their own correction dose if they become hypoglycemic with an insulin pump. Open versus closed. So open is like the old school insulin pump. Actually, the very first ones that I showed you were closed loop, but they were not really successful, so they moved away from closed loop to open loop for a while, and now the most recent trend has been towards closed loop again. So the difference basically is that a closed loop includes a continuous glucose monitor that can sense the blood glucose at any time and make adjustments in real time and then adjust the machine. So you don't have to do as much manual calculation. I mean, I think they still do enter in certain things, but you can kind of rely on the blood glucose level to adjust in real time. There is also sensor augmented, which is still an open loop, but it has it. You still wear a continuous blood glucose monitor, and then you input that information from that. But it's just the whole idea with the closed loop is that the continuous glucose monitor communicates directly without the user with the insulin pump reservoir. Just one thing about the mechanics overall is that the pump and tubing can be removed with the cannula in place. So if you're swimming or you don't want to get the device wet, although some devices are now waterproof. Okay, so this is the most important part for us, probably, is pump problems. So you may encounter this, the broken pump. Obviously, not much we can do about that. Hypoglycemia. So just to very quickly review hypoglycemia, with a blood glucose in the 80, you start to have decreased insulin secretion. When you get down to like 40, that's when you see decreased cognition, seizures, coma, and then at 20 to 10, you'll actually have neuronal cell death. So if somebody has a blood glucose around 20 to 10, it is an emergency. You're actually killing brain cells. Important to stop that right away. One thing to note is that type 1 diabetics will have recurrent hypoglycemia just due to their disease process, and that can blunt the normal counter-regulatory response. So you can have a lot of times type 1 diabetics will not have those early warning signs, and they'll just go straight into the dangerous territory. Hypoglycemia is not a reason to remove a pump. Okay, so only if it's profound, like brain cells are dying, or if it's prolonged, or if there's another pathology going on. If a patient is conscious and able to manage their pump, then you can just treat them the same way you would and don't mess with their pump. You don't usually need to follow up with complex carbs because they don't have any long-acting insulin to contend with, so no need to do much more than just dextrose. And then if they're unconscious, obviously you should disconnect the pump. For DKA, you should always turn off the pump and proceed with usual DKA management. Oh, sorry, I forgot. Cellulitis and abscess, treat it like a normal cellulitis and abscess. So take out the needle. You don't need to, just take out that part. The user can help you with replacing it, but you do want to take it out and reinsert in another site. And then one thing to note about abscess and lipo hypertrophy. So those can be confused. They do look different, but some people have mixed them up before, so don't mix them up. Lipo hypertrophy and lipo atrophy, we'll see pictures on the next slide, but those are just reactions to insulin itself in the fatty tissue. A skin reaction is very common to the tape and adhesives. It's just a contact dermatitis, nothing to worry about, but you might have to counsel them to discuss with their endocrinologist because maybe that tape isn't really working, or they can just get through it. You can also see, just one more thing on skin reaction, you could also see local edema when people first start using the pump, and that is a reaction to just having tight glucose control in the area, and it's harmless, so you don't have to worry about it. And then insulin allergy is rare, 1% to 2.4% in insulin-treated diabetic patients, but it can present as generalized anaphylaxis or a mild localized dermatitis. So this is lipo hypertrophy. Some may confuse that for an abscess. I tried to find a picture that was convincing, but couldn't find one. It looks different to me, but then this is lipo atrophy. So lipo atrophy will be like a dent. One thing to note that's important about lipo hypertrophy is that there is scar tissue under there. So if you see lipo hypertrophy, don't put the insulin pump in that site because scarring will impair glucose absorption. And then this is a picture of cellulitis or possibly an abscess. So this is just like an algorithm we kind of talked about it already, but just something that can be helpful. So if somebody comes in, they're unwell, incapacitated, or unconscious, then you want to find out first, are they in DKA? If they are, then you're going to take out the pump. If they're hypoglycemic, again, you don't take out the pump right away, but you recheck their blood glucose, you see how profound it is, right? Or if it's repeated episodes of hypoglycemia, then maybe you want to take out the pump. But you just use your common sense with that, but don't just take it out the first time you notice that someone's hypoglycemic unless they are unconscious or it's severe. This is just an important thing to note about surgery, because every once in a while we'll have someone come in and they end up needing surgery. And the floor will mostly, this is more for hospitalists, but you could help enlighten them, because chances are we don't know how insulin pumps work. Probably they don't upstairs either. So if it's an elective procedure, again, you're probably not going to see that in the ED, but they generally can keep the insulin pump in place. If it's an elective procedure under sedation and they're going to miss more than one meal, then just take it out. And then you want to start a variable rate insulin infusion. If they are not going to miss more than one meal and it's an elective procedure, so it's going to happen right away, you might be able to keep it in. But I think generally in most cases, if we are admitting someone for surgery, we are probably going to have to take it out just to help the patient. So these are just kind of the do's and don'ts to recap what we learned today. So one thing to note that I forgot to talk about is just who would benefit from a pump. It's mostly type 1 diabetics. So if you have someone, like especially a child, it's something, if you feel comfortable, you could bring it up with the mom, to bring up with the endocrinologist. It might be something that is helpful in kids. They found that actually kids who are poorly compliant will have the most benefit from switching to a pump. So if you do have a poorly compliant child in the ED, that would be a great patient to recommend. However, the parent has to be at least knowledgeable, because someone has to be responsible for putting in all those values and doing math. So you need to make sure that the patient is going to, it's kind of ironic, right? Because you want to give it to the people who are not compliant, but at the same time, they have to be ready to take on compliance in terms of operating the pump. Don't mistake, and then we are moving towards type 2 diabetics, but obviously these have to be very trustworthy patients who will, use their insulin and are excited about using the pump and are ready to use it. Don't mistake lipo hypertrophy for an abscess, and don't place a insulin pump over a site of lipo hypertrophy. Don't always trust the pump. It doesn't always indicate that something's wrong. And that's, again, don't place the pump over a scar. Do disconnect the pump if they're in DKA, if they're altered, or if they're going to be NPO for more than 2 hours. Check all the parts, so the battery, reservoir, tubing, and cannula. Call endocrine if you have to restart a pump, because there's obviously, we went over very quickly the 2 different delivery systems. That's pretty complicated. I don't think any of us have the ability to restart that. One thing about abscesses is you should culture it, because it's, you know, hardware. So treat it like any hardware. So the future is these closed loop systems that we talked about, where the continuous glucose monitor is feeding information into the device. That's basically the artificial pancreas. I thought I had it. Sorry, there was one slide that I had that showed some numbers. Oh no, I think I went over it already. But there was a recent New England Journal article that came out about the closed loop systems, and it just showed those statistics that I showed you earlier. So slight improvement in hemoglobin A1C compared to the open loop system, but fewer severe hypoglycemic events. The future also, there's going to be combination glucagon and insulin reservoir pumps. So if you become hypoglycemic and you have a glucose monitor, it will just automatically inject glucagon, which is kind of cool. And pancreatic islet cell regeneration is something going on. And also pumpless pumps. Eventually there will be no pump. They're working on like nanopolymer mediated insulin delivery. So that is it. Any questions?
Yeah, I have a question. So you kind of were saying like you either remove it or turn it off. If like they're in DKA or persistent hypoglycemic, things like that. I'm assuming it's pretty easy to turn it off. They'll probably know how to do it, and they can probably guide us through that. But is there a difference between removing it, turning it off? Like, should you just always go to turning it off? And then if you need to remove it, like, why would you remove it versus turning it off, and how do you remove it?
Yeah, that's a great question. So they actually are supposed to change the site of the infusion set. So that's the cannula with the needle and everything. They're supposed to do that every couple of days and move it to a different site anyway. So if you're going to take it out, if you're going to remove it because they're being admitted to the hospital, I would probably just take the whole thing off, because, and then when you put it back in, you just use a new adhesive set, a new infusion set. If they have a skin reaction or a skin infection, then take the whole thing off. Don't just turn off the device. If they're just, you know, someone who's like maybe doing, most of the time you're going to take it out, right? I mean, I guess you could argue that if somebody's like hypoglycemic but alert and aware, you could, but they're becoming profoundly hypoglycemic, or they are having repeat episodes of hypoglycemia, you could just turn it off, but at some point it's going to have to come off.
Okay, so they normally change that off.
Yeah.
And how do you take it off?
Yeah, I mean, I'm sure that they would know, but it's just a sticker with a cannula in it. So it's like an IV with a tiny cannula, and then you just pull it out.
Okay, cool.
Apply new.
That was a really good.
But yeah, in my research, I didn't actually find an insulin pump, so I can't say that I ever played with one of these myself. I was just looking online and talking to different people, but yeah, I'm not sure, because I've never seen one.
Yeah, me neither. Right.
Anybody seen an insulin pump in the ED? Want to share an insulin pump story?
One of our attendings wears one.
What?
One of our attendings wears one.
Oh, great.
All
I
right.
had an insulin pump at UHB the other day as well. She came in like hypoglycemic to 25 in the field. And when we got her, she was like 35 still. She disconnected it at home, so we didn't actually get to see what it was, but we just made sure that the insulin wasn't on because she was persistently hypoglycemic without a source. We ended up obsing her, but definitely something that I had to like look up online because I didn't know what to do with it. So this is super helpful. Thank you.